evening, everyone. Welcome to another important conversation brought to you by Voice of Healthcare. My name is Simiran Choudhary, and today we are here for navigating migraine with experts, not assumptions. Take control of migraine with Shape Tomorrow, an initiative by Voice of Healthcare powered by Amneal Healthcare. We all know that migraine is one of the most common, yes, yet misunderstood neurological disorders, affecting an estimated 14 to 20% of India's population, or nearly 200 million people worldwide, and significantly impacting physical health, emotional well being, productivity, and overall quality of life. Despite its widespread prevalence, migraine often remains underdiagnosed and undertreated due to misconception, delayed recognition of symptoms, and limited awareness of available treatment options. Migraine is much more than just a headache. It can affect a person's daily life, work, relationship, emotional well being, and overall quality of life. So, our aim is through today's discussion to move beyond assumption and bring evidence based perspective directly from leading experts, looking at the recognition, diagnosis, treatment, prevention, patient empowerment, and the future of migraine care. And we have an eminent panel of neurologists who will bring extensive clinical experience and valuable perspective on migraine management. Let me just take this moment to introduce our speakers. Dr. Sanjay Saxena, Vice Chairman, Neurology, Max Healthcare, Pratapganj, and Vaishali. Thank you so much for joining, sir, and welcome to our show. Thank you, sir. Dr. Dr. Jyoti Bala Sharma, Director and HOD, Department of Neurology at Fortis Hospital, Noida. Thank you so much, ma'am, and welcome to our show.
Thank you for having me here.
Thank you, ma'am. Dr. Deepak Gupta, Senior Director, Neurology at Paras Health, Chandigarh. Thank you so much for joining, sir, and welcome to our show. Dr. K. Jindal, Director and HOD at Neurology, CK Birla Hospital, New Delhi. Good evening, sir, and welcome to our show. Thank you, sir. Dr. Iqbal Singh, Consultant Neurologist at Ojas Hospital, Panchkula. Good evening, sir, and thank you so much for joining.
Thank you, ma'am, for having me.
Thank you, sir. A very warm welcome to all our distinguished speakers, and thank you so much for joining. So, let us begin by understanding the migraine beyond headache and why recognizing it is a neurological disorder is so important. To begin with, I would like to start my first question to Dr. Sanjay. So, migraine is frequently perceived as a routine headache. So, how would you describe its true clinical and societal impact in today's time?
Hi, good evening, and thank you for having me here. So, migraine is an enormous social problem which is there prevalent all over the world, not just India. And of course, India having the largest population in the world, maximum number of patients are expected to be in India. So, migraine is extremely common in certain age group. Mostly in the 20s and 30s, it builds up, and even in childhood, migraine is known to occur in children as well. So it is common in age group less than 50 or 40 years of age. After that, it becomes slightly less frequent, especially in females after menopause. So it is not just a type of headache, it is a disabling headache. And a typical attack of migraine can lead to uh, a person being out of the work, out of the home, also within the home premises, without being able to perform routine activities. And migraine has big, huge data is there. The number of days they are lost because of migraine. So it has become very important, and newer innovative treatment has been provided or being developed to give quick relief from migraine. Otherwise, as per the typical diagnostic criteria which we use to diagnose, it lasts for 4 to 72 hours if untreated, and beyond 72 hours, then it becomes status migrainosus, which is a type of emergency. So migraine is diagnosed because of its typical characteristics and the disability which it leads to in an individual who is suffering from migraine. It is much more common in females than male, and there are studies or data which says that up to 35 to 40% of the female population in the age group, young adult and premenopausal age group, they suffer from migraine uh, at least once or twice in their lifetime. And to diagnose migraine, I think the criteria, which is, I mean, we all use in our clinical practice, and for the people to understand, is easy: 5, 4, 3, 2, 1. These are the numerics which we can all, I mean, use to understand migraine. 5 is the number of attacks of headaches which should have to be included in the diagnostic criteria for migraine. 5 attacks. 4 or 3, 4 hours to 3 days. It can last from 4 hours to 3 days. That is 4 and 3. And then comes again three or two out of these characteristics. So these characteristics are that it is unilateral, though it is not always unilateral, especially in childhood and puberty or younger people. It may be a bilateral headache, but typically it should be unilateral, means one side. So migraine itself means hemicranios, which is a word in Latin and then Greek, and it's migraine is a French term, which again means one half of the head, hemicrania. So it should be unilateral. It should be having a typical character. This is important to understand. Character should be like a heartbeat, pump, pulsatile, or throbbing, or hammer-like if it is very severe, hammering in the brain. So two characteristic. Third is the severity. It should be severe enough or bad enough to make a person disabled, moderate to very severe intensity. And the fourth factor which comes into picture is the aggravation of headache with activities like walking, climbing stairs, even coughing. It can lead to aggravation of the headache for as long as it lasts. So these are the characteristics. Then there are associated features which should be there, and two or one out of these. So one of these two features is associated nausea or vomiting or both, and the second being disliking or hypersensitivity to light and sound. So 5 attacks, typical feature: one-sided, severe throbbing, associated features like nausea, vomiting, or insensitivity, hyper increased sensitivity to light and sound. And the last one is that if this is the first attack in the life, or if it doesn't fit into any criteria, or it has some atypical features like some neurological signs, some kind of systemic signs, or some metabolic issue which you can see in the clinical examination, then one is to rule out secondary causes of headache, which can mimic a migraine.
Thank you so much for explaining us that, sir, that how we can diagnose it in today's time, that and the criteria based on it. This really helps us to identify, helps put the larger burden of migraine into the perspective. Moving on to my next question to Dr. Jyoti. Ma'am, which misconceptions about migraine continue to create challenges in timely diagnosis and effective management? Because we know there's a lot of myths, around migraine and how we can actually diagnose it and have a effective management of the same.
Thank you, Simran, for asking this question. This is so pertinent. There are many misconceptions about migraine. Dr. Saxena has already elaborated about the migraine, has given the background of about migraine. The most common misconception amongst people is that it is just a headache, whereas it is much more than the headache. People who have migraine, they have severe sensitivity to noise, to light, and they cannot focus on their work. And I remember one of my patient, young boy, he was suffering from migraine. He had severe phonophobia, and he could not attend school for 6 7 months because every time the bell of the school would ring, he would again start getting the migraine. Similarly, there was another patient who had severe photophobia. The young girl would switch off the lights, even she would have dinner. The entire family would have dinner in dark when she has the severe migrainous attack. Similarly, like most of the patients, when they have migraine, just it is just not headache. It is far beyond the headache, and they are not able to focus on their work. They are not able to carry out whatever they are doing, and most of the family members, they think that it is just a headache. Why share the person is time and again having headache? They don't understand the severity of the migraine. They don't empathize with the patient. They think that why it's just for simple headache, patient is having so much of disability. That is one of the myth which most of the patients have. And the second myth which most of the patients have, most of the patients they think that migraine is not treatable. So we know that my management of migraine is a partnership between the patient and physician. So whenever patients of migraine they come to you, there are a whole lot of trigger which are present in patients. So if you do not control those triggers, you will not get the complete relief. And when they don't get the complete relief, they start thinking that probably migraine is not treatable. Third thing which I frequently come across my practice is denial. The moment you break this diagnosis that you have migraine, they would deny it outrightly. No, this cannot be migraine. It could be just sinus headache, it could be any other headache, but not migraine headache. That denial is always there on their part. And we know that not every migrainous headache is similar in two patients. So when we tell them that this is migraine, no, 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 my friend used to have migraine. This migraine is one-sided and patient has nausea and vomiting. Definitely, most of the time it is one-sided, but one can have the headache in entire head and it can be without nausea and vomiting. Like migraine can vary from attack to attack and from person to person. So this we have to make them understand that it can vary in intensity and in severity and in its like unilaterality, and it can be bilateral as well. So these are few myths which are prevalent in public, and because of these myths there is delay in diagnosis. They don't seek treatment early. Most of the time they keep on popping in over the counter pills, and once it becomes chronic and severe, then only they come to see an expert, a neurologist. Most of the time these patients are treated by ENT physician thinking it to be sinus headache, or by physician. By the time they land up with the neurologist, they already have chronic migraine or medication overuse headache or daily headache. So this is the challenge we all of us face in managing migraine.
Thank you, Mama. I think you really helped us identify the myths and misconception regarding migraine. And yes, I think it depends upon and it varies from person to person and what exactly is triggering that particular person. And that's how the cases vary from one person to another person. Thank you so much for giving us a clarification on this. As Dr. Jyoti also mentioned about the undiagnosis, because people are really not aware of the signs and symptoms and is it exactly migraine or not. So that's why I think it is that's how the undiagnosis scenario comes in the picture. So my question to Dr. Deepak is, sir, how widespread is the issue of undiagnosed and inadequately treated migraine, particularly in India and similar healthcare settings as well? Dr. Deepak, can you hear me?
Uh, Sorry, I can't hear the
Sir,
question if it is being
I'll
addressed to me.
repeat. Yes, sir. I'll just quickly repeat the question. Like Dr. Jyoti also mentioned about the undiagnosis. So, how widespread is the issue of undiagnosed and inadequately treated migraine, particularly in India and similar healthcare settings? So, can you hear me? I will, since there's some problem, our backend team will try to resolve it. I will now like to take my question to Dr. Jindal. So, could you help us understand the same question that how widespread is the issue of undiagnosis and inadequately treated migraine, particularly in India and similar healthcare settings as well? So, you're on mute, sir. Jindal, sir, you're on mute.
So, Thank you, Simran. So this is very good question regarding migraine, and because as Dr. Saxena and Dr. Jyoti has already elaborated about this migraine, because it's not just a simple headache; it's a neurological disorder, and it has so many clinical aspects. So. Regarding diagnosis, that migraine is it's a very common. It affects around 200 million people worldwide, and in India also the incidence is quite prevalence is quite high. So but most of the time this migraine remain undiagnosed, untreated, and misdiagnosis is common with case of migraine. So in my opinion, in my clinical experience of last 25 years, so I think around 60-70% cases of migraine, they remain untreated and undiagnosed, because most of the time these patients they themselves take simple analgesic over the counter pills, as Dr. Jyoti has elaborated about these, and most of the time they will go to other like ENT people for sinus headache or some other persons. So when they come to neurologists, already they are either in a chronic phase or they have medication overuse headache. So definitely this is a quite rampant problem with the migraine, because definitely it's underdiagnosed and undertreated.
Thank you, sir. Thank you so much for answering this question. And as you just explained us about the undiagnosis, we have a question from audience. I would just like to present it here. This says that I am in my third week's postpartum phase and also breastfeeding my baby. I'm experiencing migraine attack during this period. What should I do to manage my migraine safely without affecting my baby? Dr. Deepak, if you would help us answer this question.
Yeah, so luckily we are in the postpartum phase, so we have some options which we couldn't use earlier. So, first of all, simple painkillers like paracetamol to be the safest can be used. But if the requirement is more than 3 tablets or it is being used daily, then some other prophylactic migraine medications can be started for the patient, which have a low rate of excretion in the breast milk, and both nursing as well as migraine treatment prophylaxis can go together.
Thank you, sir. Thank you so much for answering. And also, if you could help us understand the key early indicators that healthcare professionals and patients should recognize to enable earlier intervention, also.
So whenever we see all sorts of patients with headache, all neurologists see in their practice on a daily basis. The characteristic of first of all, we have to make a distinguishing between what is migraine or what we call as primary headaches versus uh, what we call as secondary headaches. So that distinguishing has to be made at the primary level. So there are some red flags for against the diagnosis of migraine, like a recent onset headache, or if there is any fever, alteration of sensorium, any neurological weakness, visual complaints. So if these red flags are there, so that should deem an intervention for a secondary headache to rule out a more serious cause of a headache, which would warrant an immediate neuroimaging. But if there is a long-standing history of headaches, which is episodic or even a crescendo type building, at least 3 months, then the urgency to intervene with a neuro intervention, with a neuroimaging. Sorry, that is less of an urgency. The patient can be counseled accordingly. So I think the key early indicators for healthcare professionals and patients to recognize is first to differentiate what is migraine and what is not migraine, which can be done with simple history taking and examination.
Thank you, sir. I think this will really help our audience to understand the actual case of migraine and how they can take that ahead to their doctor. My question is, Dr. Iqbal. So there are many patients that despite experiencing symptoms for years, they delay seeking going to a specialist. What they try to do is what other panelists also mentioned. They try to take some over-the-counter medicine, some painkillers. So what factors contribute most to these kind of delays?
Thanks for the question, ma'am. But I think that it's also multifactorial
There are multiple factors which play into action for these patients. First of all, most of the patients they think migraine as a headache only, though their activities of daily life are being disturbed. But for them, migraine is just a headache. It's a trivial disease. It's not one disease that can hamper the daily life. Secondly, the awareness is still not there in the patients that we see daily on the OPD basis. They think it's a normal routine. Someone might be under stress, someone might be under lack of sleep, mild headache is there. So they just take it as a normal headache only. Sometimes people take they go to pharmacists, chemist shops. They will self-diagnose themselves as sinus headache, cervical headache, cervicogenic headache, or just because of postural headache. So they will go to these pharma shops and they will diagnose also and medicate also. Lastly, there is fear also in the patients that if we go to a neurologist, they might order neuroimaging, they might order some tests, and if we are diagnosed with migraine, then we might need to start a lifelong treatment for the same. So there's a fear in these patients that treatment cost, MRI cost will be there, and basically the socio-economic status also affects this disease a lot. Sometimes the patient they just want to get better without any treatment, so they go into alternative forms of treatment. The quacks they all play a major role. The faith, everything plays a huge role in the misdiagnosis of migraine, wrong diagnosis of migraine. So all these factors come into play when the patients know they have a headache, but still they are not able to diagnose them properly. They are not able to reach the specialists, and they are just self-medicating themselves.
Thank you, sir. I think this really gives us awareness that, just simply understanding that, yes, you might have migraine or what type of headache you have, you can really have access to good quality of treatment and exactly the right care of right treatment which is required. So I think that is the most important point here. So as we have just discussed about basic understanding of migraine, now moving on to advances in migraine science and precision therapies. So migraine has evolved considerably, and so have the approaches available to manage it. I would like to know from Dr. Sanjay, sir, how has our understanding of migraine biology and disease mechanism advanced over the past decade?
Right. So, from a social perspective, it is important to understand although the exact pathophysiology or etiology or the cause of migraine is as yet not confirmed or not established. But then we have science has been able to has been found out okay, what exactly happens during migraine. There are certain changes happen in one of the complexes in the brain, which is called trigeminal neurogenic neurovascular complex, which is a typical area involving the cranium, the eye, the surrounding eyes, the face, and the neck. So this is the area which gets affected during a bout or attack of migraine, and these attacks or headaches they are triggered secondary to some vascular or inflammatory changes in the brain, or swelling in certain areas, blood vessels, which happens inside the brain during this episode. Now it is secondarily controlled by few neurotransmitters or some substances, and most commonly understood substance which we now target is CGRP. It is a typical neurotransmitter which can lead to worsening of the pain or leads to pain, and it can last for the duration it actually does during an attack. So the most of the therapies now, which are advanced therapies, they target this particular substance, and either its release is attempted to be reduced or its receptors they are neutralized so that it doesn't act at the area where it would act and lead to migraine or worsen the headache. So neurotherapy treatment they are based on that. Abortive therapy, that means during an attack of the headache, there are anti-CGRP treatment options which work very quickly. Now available in India also. They are just oral mouth dissolving preparation which is available to abort an attack. Slightly expensive to begin with, but then the impact which is had on the life quality of the patient is tremendous. And with our personal use by all the panelists, they would agree with me that it has been quite effective managing patient who can't afford to lose a full day of the work or the requirement of the activity which he should do during that day. So he can be take just a half day or few hours leave and get back to work. So that is the wonderful treatment which has been available in India also. And then, of course, to abort an attack, there are drugs and new triptans which are available for quite long. Newer triptans have been there. The people who respond to triptan would really respond. They're very again quickly again. But these medications have to be taken at the onset or the early stages of the migraine. Once it becomes more diffuse or more longer lasting, they are probably not very effective. In that case, one has to resort to the traditional NSAI painkillers or the traditional drugs. And the most commonly used or abused drug, I would say, is a combination of one of the triptans, sumatriptan and naproxen, which is available over the counter and being prescribed by many physicians and even the neurosurgeon colleagues without understanding the repercussion it would have if it is used very often. So if it is taken almost daily or twice a day, people take it, then it leads to vasoconstriction, secondary systemic impact, and rebound headaches. So this is again a type of drug overuse or misuse, which leads to medication overuse headache. And anti-CGRP treatment is also available for prophylaxis or to preventing these attacks of migraine. So we have at least one drug available in India, which is used for once a month subcutaneously for minimum 6 months, maybe beyond that if it is effective, it is required. So we have modernization, we have understood what happens during migraine a little better nowadays, and we have many more options which will be coming up to India also in the near future.
I think so. You have given us really good points into this because to understand about what all treatment options are there to treat a migraine and how the treatment has evolved, the modernization, the new options which are there, which you also mentioned about CGRP targeted therapies, and also the misuse of the drugs which are available over the counter, and that's how it is creating another hurdle where a neurologist wants to actually treat a patient, and I think those drugs are now not very effective. Uh, Following up on the question which Dr. Sanjay has just answered and spoke about CGRP, Dr. Jyoti, I want to know with the emergence of CGRP targeted therapies, how do you envision their integration into everyday migraine care of patients?
That's a very good question, Simran. With the emergence of CGRP targeted treatment, we this has changed the treatment paradigm of migraine. We know that now we are moving towards the treatment of precision and personalization. Just like in oncology and rheumatology, we are now more and more going towards targeted treatment. Before the emergence of CGRP, the drugs which were used for migraine treatment, they were either from other classes of drugs like antihypertensive or antidepressant or antiepileptic drugs. They were not particularly developed for migraine treatment. With the upcoming of CGRP targeted treatment, we know that this is the treatment which is specifically targeting the pathophysiology of migraine. So, but these treatment, most of the time, we don't have any doubt about the efficacy of CGRP targeted treatment, but where to use these drugs? We cannot use this in all patients. So you have to choose the right patient and right time. So most of the time should be used in patients who are having frequent headaches, who are having chronic headache, who are having medication overuse headache. These are the perfect candidate for using CGRP targeted treatment. CGRP targeted treatment now people have started using them as first line also in most of the patients who have disabling migraine. But the only challenge with CGRP targeted treatment is the cost of therapy. This is not affordable by every patient. It has to be taken, though it has to be taken once in a month, but cost is a major constraint, especially in a country like India. And we know that this treatment has to be taken for a long duration. When I prescribe this patient to most of my patients, I explain them everything. They agree that they would go for this treatment. The moment they hear about the costs, they say that if you have any cheaper alternative, suggest me that first. First, I would like to try that. before going for this treatment. If cost is not a constraint, definitely this is the targeted treatment with precision and personalized care for migraine patients.
Ma'am, this really gives us understanding that how personalized treatment is also increasing and moving towards helping each and every patient based on the triggers and what problems they have. I think that's how we are evolving with the care as well. My next question is to Dr. Deepak. So, as ma'am suggested, so to what extent is personalized or precision based treatment shaping the future of migraine management in our country? Like ma'am also said, the CGRP targeted therapies is a very good option, but in a country like India, it is little expensive and affordability is one of the major concerns in our country.
So, the treatment of migraine has always been personalized from the basic preventive therapies. In that, age, gender, especially women with migraine, whether they are not married, they are pubertal, they are married, they are pregnant, they are postpartum, like we just had a question.
Yes.
uh, what is the occupation? Some patients they have night duties. Some patients have uh, duties, which expose them to various kinds of triggers. So there is no the treatment of migraine has to be tailored with respect to each patient. And now with these new therapies coming up, cost is also an issue. Definitely, people who are still disabled by their headaches, despite the conventional oral prophylaxis, they have a good option with CGRP antagonists. Cost may be an issue, but some other alternatives, like behavioral lifestyle modifications, can also help to a large extent in these patients. With the coming of these neurotransmitter and receptor side based therapies, the migraine prophylaxis, acute treatment, abortive treatment, preventive therapy has got pretty revolutionized, and we have much more medicines to give to each patient, because there are some patients who won't respond or who are not candidates for the conventional preventive therapies. Uh, like PCOD or obesity or uh, uh, menstrual disturbances are a big hindrance to use of divalproate or valproic acid. Some patients are unable to tolerate basic medications like topiramate. And what evidence says is that the other conventional therapies which were used in the prevention of migraine, they don't help much. So definitely, one, it was always personalized treatment. You have to tailor it to the patient. Secondly, you have to see the patient characteristics right from age, gender, occupation, the cost thing. Thirdly, you have to discuss out with the patients, and if the patient is willing, depending upon whatever his or her characteristics, the precision-based treatment has revolutionized the treatment of migraine and made the patients have a lot more productive days in a week or in a month.
Thank you, sir. Thank you so much for explaining the personalized treatment um, for migraine care. As we are moving ahead with the technology and advancements which are increasingly relevant in how neurological conditions are diagnosed and monitored, I would like to ask my next question, Dr. Jindal. So, when we're talking about advancements, innovation, which is going hand in hand and rapidly evolving, and we know that in every sector it is playing a very important and major role. So, how are these advancements in imaging, biomarkers, and digital health tools enhancing the diagnosis and monitoring of migraine for today's times of patient, specifically focusing on our country?
So, Simran, uh, like migraine, as we are discussing, that it's primarily a clinical diagnosis. So, it's diagnosed based on detailed history and according to international headache criteria. So, regarding the use of imaging in migraine, in the case of typical migraine, we usually don't require an imaging, but to rule out secondary causes, basically to exclude the other causes of the headaches which can mimic like migraine. We need imaging, MRI or CT scan. So then coming about the biomarkers. So one of the biomarker that has been extensively researched, and based upon that marker, the this present day CGRP molecule that has been anti medication that has been developed. So this is the biomarker, but as such in clinical practice there is no as such biological marker with the help of which we can diagnose or treat this thing, migraine. So, but definitely with this CGRP, we are able to provide targeted therapy or precision therapy. So then coming to the digital this thing. So I think in case of migraine, so digital devices or keeping a mobile headache diary helps to maintain the note the headache severity, headache frequency, severity, or any triggering factors. And maybe in coming future, some AI based devices or predictive model may be helpful to predict the impending migraine attacks. So with the help of these devices in future, maybe it may become more easier, or at earliest we can diagnose the migraine attack and treat accordingly. And with the help of these digital devices, I think a patient may be able to collect the objective longitudinal data, so that can be provided to the physician. And with the help of this data about that patient's regarding frequency, severity, triggering factors, so physician, it can help the physician to target the therapy for that particular individual. So I think that will be very good for the coming future for monitoring the treatment of these patients.
Thank you, sir. I think that is a very important aspect which you have explained, that as of now there's no particular biomarker in diagnosing this, but yes, we are moving ahead and we do have some advanced treatment options which is available. One of them is what you also mentioned about CGRP targeted therapies. As we move ahead, my question is to Dr. Iqbal. So, beyond pharmacological treatments, which evidence based lifestyle and behavioral intervention have demonstrated meaningful benefits to migraine for migraine patients? So, you are on mute, sir. Yes.
Like in my OPD, I always advise my patients to follow both pharmacological treatment and the non-pharmacological treatment. And both of these treatments, they should add to each other. It's not like you have to follow just one treatment and to get the other part. In the non-pharmacological treatment, the most important is you should make the patient know that what things can make your migraine even bad, like lack of sleep, any kind of sleep deprivation, any kind of pungent smell in the house, like perfumes or any kind pungent of smell elsewhere in the house, going out in the sun, going out in loud environment, like any kind of marriage or any function in the house, any kind of long travels, whether it be a plane travel or a heli travel. So all these, and every patient has its own individual factors which make a migraine worse. Secondly, we should follow migraine diary. Migraine diary is actually proved by the WHO also, that patients should follow migraine diary, in which there is the exact number of days the patient is having a migraine attack. What is the severity of the headache? So, individualized migraine diary we should give to every patient who's there in our OPD. And secondly, patients should follow a routine for their healthy lifestyle, adequate hydration. They should follow healthy lifestyle, and then they should know that which things are responsible for the worsening of their attacks. Like some patients, they tell us that excessive sleep, lack of sleep is one of the most common risk factors for the migraine. Any kind of excessive sweat in these in this some summers, this also leads to a lot of migraine attacks. So along with this, regular exercise is also important. Patients should indulge in aerobic exercises along with, and do some bit of yoga in the morning. Along with, patients in this lifestyle have a lot of stress also, due to their jobs, due to their family, and everything else. So behavioral therapies, biofeedback, all of these plays a huge role in the management of migraine. It's not just medications that we have to start with the patient. All of these other lifestyle lifestyle the patient should follow for the complete treatment of their migraine.
I think so. You rightly mentioned about maintaining a diary and having a combination of pharmacological treatment and the lifestyle management as well. Because I think only just with lifestyle management, or let's say only with the treatment or the medicines, things will not work, or it will not be fast enough for a patient's recovery. So both the things are required, and maintaining a migraine diary would really help the patient also to understand what is triggering them, and it will really give a clear history to the clinician also to understand that particular patients attacks, trigger points, and how to treat it. So I think that is a very valid point you addressed, sir. As we move ahead to the future of migraine care and patient empowerment, I would like to ask my question, Dr. Sanjay. So, how can healthcare providers move from just treating migraine episodes to adopting a more proactive, preventive care approach?
So migraine is again sort of lifestyle disease. So unless you understand your own personal parameters or factors which trigger migraine, uh, then alone pharmacological treatment or taking painkillers very often is really detrimental, and it can lead to in fact a negative impact on the outcome of the migraine. So it can affect your life adversely. So, future lies in having an environment which is obviously much more congenial, lot of relaxation to the mind. We are in no hurry. I wish that is a possibility as in near future. Here we are seeing war everywhere, and we are bombarded with all kinds of protest, unrest, everything. So that we imbibe in our minds, and that is one reason why our sleep quality of sleep is really very poor. Either we sleep at late hours, get up at even later hours, so that really affects the sleep cycle, can trigger a migraine, and one of the important triggers. So we have to identify the triggers. Coming back to triggers, another important thing is now keeping yourself fasted. So fasting for longer duration or skipping meals is a very important trigger. At the same time, there are a number of internal or hormonal changes which occur in a female, which can also trigger migraine. So we have to identify what are the factors which can influence our migraine or our quality of life, and if we can modify these factors, avoid these factors to our best capacity, then of course we have good response from the pharmacological treatment. And above that, we had very good device which was developed very effective in some patient, remote electrical neurostimulation. There is a device which can be just like a BP cough can be placed on the arm, and it gives a feedback to the trigeminal neurovascular complex and inhibits progression of the headache, controls the headache. So there are certain more neuromodulatory devices which can be used, like TMS, transmagnetic stimulation, single pulse. Then you have some more devices which can influence the vagus nerve externally, or even the trigeminal nerve. So these all are there. They are associated treatment options which can be utilized, apart from the nerve blocks which we give in certain situations, certain patients. So looking ahead, the lifestyle remains the most important thing, because migraine has got external and internal triggers both. External triggers, if they improve, internal triggers will also be taken care of a little better, and internal triggers we understand we can control. So looking at migraine is not going to get better any better. This is what my I mean, I wish I'm wrong, but that is what I predict. But at the same time, we will have better options, so we can always talk about treating it rather than preventing it. So if we focus on prevention, that is probably going to control migraine epidemic, or it is all over the, it's a pandemic. All over the world you have migraine, and every household has a migraine here, irrespective of the age also, right from the small child to the elderly people.
So correct me if I'm wrong here, where you mentioned about the stress point. I think migraine or let's say any other disease we talk about is only a modern day disease we're talking about, and I think these were never there when the times were different, and stress is one of the factor. And when we talk about India, it is a diverse country, right? And living in a metro city or people living in tier 2 tier 3 would have different kind of lifestyle, and their problems would be different. So in healthcare access and disease burden, there's a significant difference across region. So are there any meaningful regional variations in migraine prevalence, triggers, and access to treatment across the different parts of India when we talk about the remotest of the area or the tier 1 or the metro city of our country?
So obviously the awareness is more in the metropolitan cities, or the cities where the people are educated. They understand, and more a person is educated, more he is prone to all these external environmental triggers of migraine. So awareness is much more, so that it's picked up and diagnosed more often in the cities, tier one or tier two cities, even tier three. But when we go to the rural background, the atmosphere is different. People are not aware, and even if one has got a migraine, which is probably a familiar or genetic predisposition is also there, then its occurrence would be much less, just once in a month or 2 months. So that can be managed by that individual. He never goes to the treatment. But then if there is a severe migraine attacks to a lady or a female in a rural area, the treatment options are very limited. They are left with Saridon or Anasin and those kind of stuff which were available in India for last 60, 70, 80 years, but not now as a recommended treatment. And they become dependent on these medicines, and it converts into a either a chronic migraine or medication overuse, headaches, and all those things. So lack of awareness, lack of facilities, though the incidence and prevalence is much less in the areas which are away from these hustle bustle life. Obviously, that is the gap, I would say, but at the same time, the incidence is also lesser. Then the people who are in high altitude or area where the climate is better, they have lesser migraine than these polluted cities where we have to live our lives.
Thank you, sir. Thank you so much for clarifying the difference in the regions where we all live in, and I think how the cases can also vary. As we are moving ahead, I would like to take my next question, Dr. Jyoti. Ma'am, how do factors such as urbanization, environmental exposures, changing lifestyles, and workplace stress influence migraine burden across regions? Ma'am, you're on mute. Yes,
That's
I
a
can hear you.
very pertinent question, partially answered by Dr. Saxena. I would say that urbanization is perfect recipe for triggering migraine. We know that in urban life, you have late nights, you skip your meals, you have easy access to junk food, and you have a lot of stress. Even if you have to commute from workplace to home, that itself is a stress. On the top of that, there's so much of pollution, and all this, and you are not connected with your family member. Most of the people, they live in nuclear family, so you do not have that sharing of that stress. So all these factors in urban life, they contribute to increased number of migraine in patients who is already predisposed. So urbanization, on the contrary, if you compare it with rural life, those patients, they definitely do not have that stress, but at the same time, if they suffer from migraine, they are underdiagnosed and undertreated. Most of the time we have seen that ladies, they just tie their head with dupatta and just continue working until unless it becomes so severe that they have to seek treatment. So as Dr. Saxena has pointed out, that gap has always been there, but urbanization has definitely triggered it. So migraine, I would say that migraine is a genetic problem, but it is influenced by environmental factors. So genes are like a loaded gun, but all these factors, they pull the trigger. So you have abundance of these factors in urban life, which which precipitates the migraine. But at the same time, you have easy access to healthcare in urban setting. So your treatment is better if you have easy access. But adherence to treatment is again an issue in urban life because you're so occupied with so many things. You're doing multitasking, so you hardly have any time for yourself. So you're always running, but you're always short of time. So that's the challenge in urban life.
Agreed, ma'am. I think urban life has both its pros and cons, and adherence to treatment is one of the major problem which I think doctors face every day with every patient. I think that's what's their biggest problem is. As we're just talking about the urbanization and the challenges we have, I have a very relevant question to what we are talking from my audience. I'd just like to present that. So the question is, what should I do when a migraine attack starts during working hour in my office and my manager does not support me? Jyoti ma'am, can you help us, please?
So we have many medicines. We have migraine specific medicines as well, which are working specifically for migraine. So the moment you have symptoms of migraine, you should not delay taking these medicines. If you take them early, you get best response, right? And these are the abortive medicines. So these medicines can abort the attack of migraine, but definitely you have to avoid the toxic work environment. If like for that, all we need is to educate the people about migraine and its consequences, because migraine by most of the people are taken as just a normal headache. So most of the time when even the employee would say that they have migraine, their boss would think that it is just an excuse. Nobody understands how severe the migraine can be. It is not just an headache, it is much more than just a normal headache. So, this understanding would come with spreading awareness as you are doing. More we spread the awareness, more people will be aware, and more they can empathize with the employee who is having migraine.
I think that support, that education, that awareness is required. That's why we want, everyone to create awareness around this. As we're moving ahead, I would like to take my next question, Dr. Deepak. So we are talking about accessibility or reach of awareness and education about migraine to all the areas. So, what are the key healthcare system challenges must be addressed to ensure equitable migraine care in tier 2, tier 3, and the rural communities as well? Sir, can you hear me?
In the meantime, till he rectifies his issue,
Sir,
going back to the question which was asked. So there is another trigger here. His
sir.
boss, the manager. So that needs to be taken into account, and he should be educated. Boss.
I think that should be mentioned into a migraine diary also. Dr. Deepak, can you hear us? Okay, he's not here.
Not there.
I think sir has joined. Dr. Deepak, can you hear us? So can you please help us understand that what key healthcare system challenges must be addressed to ensure equitable migrant care in tier 2, tier 3 and the rural communities as well? Deepak sir, can you hear me? I think there's some issue at his end. Um, I would like to take my question from Dr. Jindal. So, should migraine receive greater attention within India's public health priorities and non communicable diseases strategies? And if yes, why?
So, absolutely, Simran. As we have discussed, that migraine is one of the leading cause of disability, especially among patients in their productive years, like less than 50 year of age, and it affects millions of Indians. So, it has enormous impact on this socioeconomic burden, and because of substantial losses in the productivity, school attendance, and quality of life. So, in my opinion, recognizing the migraine within India's broader non communicable disease framework would promote early diagnosis, and it will improve access to the evidence-based treatment, and it will reduce the long-term disability. So investing in migraine is not merely a healthcare priority; it's an investment in the workforce productivity and national economic well-being. So I think, in my opinion, this migraine care should be included within the broader non-communicable disease framework.
Thank you, sir. I think we all would agree to this point that it should be included in the policies, and how it can be, the treatment can be made accessible to every corner of India, and for greater awareness. My question is, Dr. Iqbal, sir, if you had the opportunity to advocate for one policy intervention to strengthen the migraine awareness, diagnosis, and access to care, what would it be? And also, if you could share a closing message, or let's say an awareness message in the regional language, so that we can have a better connect at the audience present in Punjab. So you're on mute, sir.
Should I start in Punjabi from the beginning or at the end only?
So however you like to take it, a closing small line would in Punjabi would also be good, sir,
Okay.
or a normal message.
So one thing that I would like to do as a healthcare professional, that we should integrate the primary healthcare into the migraine care. We should not establish more of neurologists, more of persons who are headache specialists. The primary healthcare, the PHCs, the health centers, the Anganwadis, they should be trained. The healthcare professionals at that level, the pharmacists, the chemists, every person who is the first medical contact to the patient, either in the rural setting or in the urban setting, they should be trained enough. They should be specialized to handle a case of migraine, or even, let's say, diagnose a migraine and start the basic treatment. And if the case is not settled at that level, primary level, then it should be referred to a secondary or a tertiary center. That I don't think the solution is making more neurologists go into the field, or just creating more neurologists by adding more seats. We should strengthen the already existing system that's already there. Given the so much of population in India, even creating more doctors won't find a solution to it. सो इसको अगर इसमें हिंदी में बात करनी हो तो बेसिक ग्राउंड लेवल पे हमें मेहनत करनी चाहिए. जो बेसिक PHCs हैं, प्राइमरी हेल्थ केयर सेंटर्स हैं, कम्युनिटी हेल्थ केयर सेंटर्स हैं, उनमें वी शुड गो. गवर्नमेंट शुड मेक सम इनिशिएटिव्स कि वहाँ पे माइग्रेन की अवेयरनेस हो रिगार्डिंग ऑल द इलनेसेस. जैसे हार्ट, आवर हार्ट इज सो, यू नो, everyone worries when there is a chest pain, but no one worries when there is a pain in the head. They take it so normally. So जैसे दिल है वैसे ही दिमाग के बारे में लोगों को चिंता होनी चाहिए. So that we can provide right treatment at the right time to the right patient.
Thank you, sir. Any line would you like to say in Punjabi to your audience, and then we can also have that connect with them?
इन पंजाबी मैं यही कहना चाहना कि माइग्रेन सिर्फ सिर दर्द नहीं है. सारे व्यूअर्स ਨੂੰ अपने माइग्रेन सिर दर्द तो बहुत ज़्यादा है. ਸੋ ਕਦੇ ਵੀ ਤੁਹਾਨੂੰ ਲੱਗੇ ਕਿ ਇੱਕ ਪਾਸੇ ਸਿਰ ਦਰਦ ਹੋ ਰਹੀ ਹੈ, ਜਿਵੇਂ ਕੋਈ ਥ੍ਰੋਪਿੰਗ ਹੈਡੇਕ ਹੈ, ਜਿਵੇਂ ਅਸੀਂ ਪੰਜਾਬੀ 'ਚ ਕਹਿੰਦੇ ਹਾਂ ਨਸ ਟਸ ਟਸ ਕਰਦੀ ਹੈ ਇੱਕ ਪਾਸੇ, ਉਲਟੀ ਦਾ ਮਨ ਕਰ ਰਿਹਾ ਹੈ, ਸ਼ੋਰ ਸ਼ਰਾਬੇ 'ਚ ਦਿੱਕਤ ਵੱਧ ਜਾਂਦੀ ਹੈ, ਤਾਂ ਕਦੇ ਵੀ ਇਸ ਚੀਜ਼ ਨੂੰ ਇਗਨੋਰ ਨਾ ਕਰੋ. ਇਹ ਸਭ ਸਿੰਪਟਮਸ, ਇਹ ਸਭ ਲੱਛਣ ਮਾਈਗ੍ਰੇਨ ਦੇ ਹੀ ਹੋ ਸਕਦੇ ਨੇ. ਮਾਈਗ੍ਰੇਨ ਦਾ ਇਲਾਜ ਅੱਜ ਕੱਲ੍ਹ ਬਹੁਤ ਈਜ਼ੀ ਹੈ ਐਂਡ ਬਹੁਤ ਐਡਵਾਂਸਡ ਆ ਚੁੱਕਿਆ ਹੈ. ਨॉट जस्ट ਸਿੰਪਲ ਮੈਡੀਕੇਸ਼ਨ. ਅੱਜ ਕੱਲ੍ਹ ਬਹੁਤ ਨਵੀਆਂ ਦਵਾਈਆਂ, ਬਹੁਤ ਨਵੇਂ ਇੰਜੈਕਸ਼ਨਸ ਵੀ ਆਉਣੇ ਸ਼ੁਰੂ ਹੋ ਗਏ ਨੇ. And बहुत neuromodulatory devices, like sir already told, VNS, TMS, remote neuromodulation techniques. So migraine is not just paracetamol or naproxen or sumatriptan. It's much more than that. So कभी भी इस तरह डाउट लगे, always consult your doctor, if possible a neurologist, but don't ignore your symptoms. ਤੁਹਾਡੀ ਲਾਈਫ ਬਹੁਤ ਜ਼ਰੂਰੀ ਹੈ, ਤੁਹਾਡਾ ਲਾਈਫ ਸਟਾਈਲ ਬਹੁਤ ਅੱਛਾ ਹੋਣਾ ਚਾਹੀਦਾ. ਐਂਡ ਜਿੰਨਾ ਧਿਆਨ, ਆਈ ਵਿਲ ਅਗੇਨ ਰਿਪੀਟ, ਜਿੰਨਾ ਧਿਆਨ ਅਸੀਂ ਦਿਲ ਦਾ ਰੱਖਦੇ ਹਾਂ, ਉਹਦਾ ਥੋੜ੍ਹਾ ਪਰਸੈਂਟੇਜ ਦਾ ਅਸੀਂ ਆਪਣਾ ਦਿਮਾਗ ਦਾ ਧਿਆਨ ਰੱਖਾਂਗੇ, ਤਾਂ ਦੁਨੀਆ ਬਹੁਤ ਅੱਛੀ ਹੈ.
Thank you, sir. Thank you so much for this message, and how it is important to take care of our brain as we do take care of our heart. Because जैसे सर ने बोला, हम दिल के दर्द पे इतना घबरा जाते हैं और इतनी चिंता करते हैं, उतनी चिंता हमें अपने सर दर्द की भी करनी चाहिए. सोचना चाहिए कि क्या लाइफस्टाइल प्रॉब्लम्स हो सकती हैं, कैसे ठीक हो सकता है, कब डॉक्टर के पास जाएं, कैसे इसको ट्रीट कराएं. So thank you so much to all the panelists present here. As we have come to end of today's conversation, this one message is clear that stands out is that migraine should not simply be dismissed as a routine headache. Greater awareness, timely recognition, appropriate diagnosis, individualized management, and continued patient support can all play a very important role in improving the migraine care. I would sincerely like to thank all my panelists, Dr. Sanjay Saxena, Dr. Jyoti Bala, Dr. Deepak Gupta, Dr. K. Jindal, and Dr. Iqbal Singh for sharing your valuable expertise and perspective with us today. This has really helped us to create greater awareness and education amongst our audience. Thank you so much for coming to this platform and giving your valuable time and expertise with us. Thank you so much to all.
Thank you,
Thank you so
Simiran.
much.
Thank you,
Thank you,
Voice of
Chandu.
Health. Keep raising your voice at the loudest possible level, but don't trigger a migraine. So sound can trigger. So keep yourself in limelight, but not in the headlight. So I think you have a bigger responsibility, important role to play to spread awareness than we clinicians. The patient will only come to us once they are aware that they have to go to clinician or doctor. It is your equally or maybe more important than all of us. Thank you for organizing this. Thank you.
Thank you, sir. Thank you so much for these words. Thank you.
Thank you and good night.